afternoon of February 7th still, and we're continuing our conversation today around sort of the intersection between education and healthcare. And so we've invited in lots of people to talk about teacher health insurance. I have to be honest with you, a lot of this testimony is because frankly, I don't understand how it all comes about. So I'm hoping that the people in the room can explain to us how things happen and about their plan. So we're going to start with Mark and
Bobby Joe.
Bobby Joe.
Good afternoon.
Good afternoon. Thanks.
Bobby Joe, my colleague, is with us virtually. Hi. It's a pleasure to be here in person. I was unable to do so earlier this week, so I appreciate the opportunity to make up for that failing. For the record, my name is Mark Hage. I'm the Director of Benefit Programs at the Vermont National Education Association. I'm here today, though, in my capacity as a VHI, Vermont Education Health Initiative Trust Administrator. I'm appointed to that position by Vermont NEA and my colleague.
Hi, my name is Bobby Jo Sauls, and I work for the Vermont School Board Insurance Trust, and I am also a trust administrator. VHI does not have any employees exactly, so they contract with both the Vermont NEA and Vermont School Board Insurance Trust to provide services for both the employer groups and the employees.
We have several other colleagues in that capacity who will not be here today, but for whom we will speak and reference some of their work. We will also address our governance model, which is different from the service model in due course. So once again, thank you for the opportunity to testify. We will shed as much light as we can on the complexities of commercial health insurance in the public education realm and how VHI structures its work and its mission. I think the first thing we want to be clear about today is that VHI is not alone in facing rising healthcare and commercial insurance costs. This is a regional and national problem, and it's severe. And this is particularly the case when we talk about hospital costs and pharmaceutical costs. And we will be digging into some very deep numbers today in both of those realms. All self-insured risk pools and commercial insurance carriers are confronting the same systemic problems and cost drivers and the challenges that they pose. And again, I think that will be very clear today as we speak about our work at VI. Most of the information we're going to share today about premium rates, cost trend, cost drivers, the allocation of our spending, the nature of our plans will be focused on 2 years, FY25, the year we're in currently, and FY26. We operate on a fiscal year basis when it comes to setting premium rates. I'm going to let Bobby Jo take the first part of this presentation, which will introduce you to VHI, a little bit about our history, how we're structured, how we're governed. She can also walk you through some of the premium numbers as well. And then I'll take you on a deep fishing dive into some further data that I think will be very illuminating, at least I hope so. Ms. Sauls?
Yes, sir. And I would like to welcome folks to ask questions along the way.
Yes, thank you.
As the lady said at the beginning, it is a lot of information. It's a lot of numbers. And it is, I think, confusing for those who don't dive into it on a daily basis. So we're welcome to take your questions. So VHI, Vermont Education Health Initiative, we refer to it as VHI, was established in the early 1990s. We're a nonprofit, we're self-insured, we're considered an intermunicipal insurance association. We are regulated by the Vermont Department of Financial Regulation. They review our rates filing every year and approve it. We contract with Blue Cross and Blue Shield of Vermont for actuarial services as well as administrative services. But we are a fully a self-funded pool. So Blue Cross is a TPA of sorts for us who processes the claims. But we own the reserves and we manage the reserves. So we provide health insurance benefits to every public school in Vermont and to some independent schools or private schools as well, if they choose to enroll with us. We also offer a retiree benefit to the Visters group, the Vermont State Teachers Retirement System. We have about 1,000 members in that group, or excuse me, probably closer to 1,600 in that group that are either prior to Medicare eligibility, or they have the Vista 65, which is basically a Medicare supplement plan. Another probably 6,500 have a plan outside of us now. Up until 2022, they were with us. So we have about just under 35,000 active school employees and dependents. And again, as I said, and then an additional 1,800 people who are on the Visters plans. Our board of directors consists of 6 different members. We have 3 that are appointed by the Vermont National Education Association and 3 that are appointed by the Vermont School Boards Association. So we have a board of 6. And then we have our management team who is responsible for day-to-day operations. That is myself, Mark, and then also John Steiner is the president at Visbit, and Chris Roberts handles all the finance as part of the work that we do in our service agreement for VHI. Most interactions really go between Mark and I. We handle the majority of the day-to-day work with the group and the employees. We also offer dental and life and LTD programs, so long-term disability and life insurance to employees of schools as well. And we have our PATH Wellness Program, which is a long-time, well-running wellness program that we have for all of our active employees and our retirees as well. Beginning in 2018, we offered 4 new health insurance plans to all of the school districts. And there is a page down at the end that shows what those, kind of a highlight of what those plans look like. The Medicare supplement plans and the pre-Medicare plans are different from our active employees. We set, with the help of Blue Cross, so Blue Cross identifies the number of claims that we have. They identify upcoming trends, prescription drugs coming down the pike, and they help us determine what our rates should be set at for the next fiscal year. We do rate well in advance of our rate, and so we just received our rate approval for FY26, which starts in July of 25, that runs through June of 26. So we have to, this began last summer. So it's really an early process to make sure that districts have the rates in advance of town meeting and budget setting processes. So we set these on a fiscal year basis for active employees with the Blue Cross actuarial team. And then we bring that information to our board, and the board sets the rates depending on what the Blue Cross actuaries provide to us, and as well as the current status of our reserves. Obviously, we have to have reserves in place to cover expected costs and unexpected costs. Our premiums, let's see, I'm sorry. All right, we talked about that. So as far as cost sharing between the public school boards and the public school employees for health insurance is set by the terms of the statewide bargaining agreement. This went into effect, I think, in 2021. This includes both cost sharing amounts for premiums and out-of-pocket expenses, including things.
Joe,
yes.
May I interrupt you for just a second? We're having a bit of a technical difficulty with the slides that were sent.
What slide? Oh, there were.
You mean the written testimony?
The written testimony.
It's gobbledygook.
Really?
Yeah.
Would you like to share my
email? And,
Actually, that would be helpful.
Yeah, if-
Bobby Joe, share with me again. I'm sorry, that's never happened before.
Let's share your screen. That would be terrific.
Just so you
All right, I'm just sending a request over.
That's.
It'd be nice to resend this when I get to the office. Or you can let me know if it,
Can you see it okay now?
Yes.
Okay, great. All right, so again, the cost sharing So who pays what for the premium, how that's split between the district and the employee is set by the statewide bargaining committee or commission, excuse me, and as well as out-of-pocket expenses. So our plans have deductibles and co-pays and co-insurance, and there is some cost-sharing funding in place set by the statewide bargaining committee, or excuse me, commission, to help offset some of those costs for employees. And then if we get down here, so these are the last two rate cycles. The current rate cycle we're in today is FY25. That goes through the end of this June. Last year we had an average increase of about 16.4. And then we also have, this year was lower, thankfully, at 11.9, but still double digits. And you know, despite some of these higher rate increases, we've still had a couple of years of high claims costs, which have, you know, played into that, not only needing the rate increase for the increase in costs, but also to kind of reestablish or replenish our net position, which has hit some turbulence the last couple of years. So this is the graph that we send out each year for our employer groups to review, as well as our board, of course. And this reviews for every dollar that we take in, this is where the money goes back out. And that giant blue piece, almost 89%, is purely claims. So that is claims that come into Blue Cross. Blue Cross pays them out of a fund of money that we have on for them, or have on file for them, and we replenish that on a weekly basis. We pay out about, or Blue Cross pays out on our behalf, about $6.4 million per week on healthcare costs. So obviously we're talking about some really big numbers here. So again, almost 89% is claims alone. Blue Cross administrative charge is 3.7%. So sometimes we talk about, you know, different health plans or carriers, but really the amount that we're paying Blue Cross is 3.7% overall. State and federal assessments is 2%. VHI program, I'm sorry?
No, there was just a
comment. VHI programming, so what is paid for both VSBIT and for Vermont NEA to do work for VHI is 0.5%. Our wellness plan is 0.6%. And then last year, or in the year that we're in, we put in 3.2 toward our net position. And again, part of that being to rebuild from a couple of years of losses. Mark, are you going to go ahead and take the next part?
Happy to. Should we pause for a moment? Any questions on that information yet?
What was the amount?
Yeah.
Can you repeat the amount?
The weekly claims? In FY25, we anticipate on a weekly basis to pay $6.4 million in claims.
Per week.
Per week, right, weekly basis, 6.4.
And I know we talked about like fiscal year and
FY25
so your plans go in effect from July 1st.
to June 30th, correct.
And so that's why you have, I'm assuming, already your fiscal year 26.
Correct. And as Bobby Joe said, we set our rates well in advance of when they go into effect to accommodate school budgets.
Mhm.
That is not common in the commercial insurance market, generally speaking, but in our world, it's very important. As you can appreciate, that school boards have that information as soon as possible.
So just to be clear, last year there was essentially over 16% increase.
Correct.
And this is now
Excuse me.
12%.
FY25, the year we're in, was the 16% you alluded to. FY26, the year to come, 11.9%, roughly 12%.
And to be clear, just regarding plan, the fiscal year versus calendar year, our plan designs are set up for calendar year, but our rates change fiscal year, just as a clarification.
It's much easier to administer out-of-pocket cost sharing with HRAs, HSAs, FSAs on a calendar year basis. But as Bobby Joe said, the rate setting is structured on a fiscal year basis.
I'm sorry, I'm just 28% in 2 years.
That's a lot of money. Yes, ma'am.
Yes, I'm sorry,
If I
Leslie.
understand this right, you're saying that you have 35,000, almost 36,000
right.
people. And of that 36,000 people, you are paying $6 million a week
In claims,
in
projected,
claims.
correct.
So can you help break that down?
That's the next part of the
That's the next
presentation for
thing.
you.
Excellent, because I'm saying, wow, that's
Right.
right.
So what explains those costs? And by way of preface or foundation, if you look at this issue from a state basis, New England basis, or national, you're going to find the same phenomenon at work. Most healthcare spending in any of those geographic domains is driven by a relatively small number of people. Healthcare spending is highly concentrated among a relatively small number of people. The federal government has been tracking this for nearly 50 years, and you see the phenomenon nationally as well as here. And it's very similar to what we experience in Vermont to what other states and the country as a whole experiences. And these numbers, I think, will illuminate that. And this is where Bobby Joe and I spend a lot of our time with these numbers, trying to understand them and then trying to mitigate these costs to the greatest extent possible without compromising access to affordable care. So when we look at the costs of VHI, again, you're going to see the same phenomenon with other pools and nationally. Most of our costs are hospital-based. 55% of our claims are attributable to hospital services, inpatient and outpatient. 20% of our claims roughly are attributable to pharmaceutical costs.
You have a slide on that?
There's more information coming.
Okay.
Yeah.
Okay, just so I'm on the same page here. Okay, 35,000 or 36,000 clients. That's not counting the retirees.
If the 36,000 is our aggregate number for members, subscribers, we call them,
Okay.
that would be active and retired. The costs we're going to be drilling into today are particular to active employees. Okay.
And that's about 34,500.
34,500, give or take.
So that's members, that doesn't include.
Okay, yes, no, these are very good questions. And Bobby Joe and I use the word member somewhat loosely in our work. Oftentimes when we're working together and we say members, we're talking about school employees, licensed and non-licensed, and their dependents. When we're sitting down with our colleagues at Blue Cross Blue Shield of Vermont and we're doing actuarial analysis, we tend to distinguish between member groups, which would be school districts and the Vermont State Teachers Retirement System, and the private institutions that Bobby Joe alluded to, and subscribers being the individual lives, family member, dependents, et cetera. So probably today, to keep it simple, when we say members, we're talking about human lives, and both employees and their dependents. So 55% hospital claims, 20% RX. 4% of our claims are attributable to primary care services, and about 12% to specialty office visits. When we explained to our groups, school districts, and to local union leaders and their members, what was driving these costs in the last 3 fiscal years, 2 in the past, 1 to come, 24, 25, and 26, you will see on pages 6 and 7 of this testimony, once it is no longer garbled, the emphasis that we place on price inflation, because the fundamental driver, and I'd give the same speech if the Maine legislature asked me to come and talk about this tomorrow. The main driver is price inflation. You'll see in 2024, we said increases in medical and pharmacy prices are responsible for virtually the entire increase in FY24 premiums, with high commercial rates charged by hospitals being the most significant factor. Now, there are other factors as well. Clearly, we suffered some losses in investments in the market, but the main drivers is medical price inflation. That was the FY24 message. The FY25 message, very similar. 2/3 of our price increase, our premium rate increase, was attributable to higher medical prices. And here, Our colleagues at Blue Cross Blue Shield of Vermont echo that sentiment, saying Blue Cross and Blue Shield of Vermont noted that the main driver of premium increases in FY24 is rising hospital budgets and the cost of inpatient and outpatient services and pharmaceutical prices. Now, we are also seeing an increase in utilization in FY25. That too is a regional and national phenomenon. We attribute it largely to a post-COVID, post-pandemic environment. An awful lot of people deferred essential, necessary care during those periods. We believe that is a major factor behind this. There may be other factors as well. I think we will know probably a few years down the road when researchers and analysts and actuaries start digging into the data better and deeper, what other factors may be behind it as well. But again, we are not alone in seeing this utilization increase.
Can I ask a question real quick? So a couple different numbers, particularly up a little bit when prescription medications, 20% of total spend. You have 4% of claims attributable to primary care.
Right.
So not 4% of your total spend, but like if you just took all the number of claims you had, 4% of them are primary care.
That may not be correct. I think
Yeah,
it's
that's a great-
4% of
that's a
our,
good-
I think it's our
that's a good
spend, Bobby
definition.
Joe.
Let me look at it real quick and see how it's written.
I think that's a misstatement. I think what we were trying to do here is to break
I
down.
think it should be total spend.
Yes, I believe it is. It's 4% of total spend and
But that's
12%
a
on
great
specialty.
catch because those are
Yeah,
different
thank
things.
you. Next time you invite us in, I'll make sure that's corrected.
And to follow up, just because I hear utilization used in different contexts, I think of utilization as like discrete increase in the number of claims, but I hear it sometimes referred to increasing utilization as like higher dollar amount of claims. I mean, are we talking about a third is an increase in the number of services that people are receiving, or is it that the claims are just higher?
I think Bobby Joe, correct me if I mistake this. I think it's both. I think it's a combination of more services are being sought and the acuity of care is greater. Those two factors explain utilization numbers.
Okay.
Bobby Joe, did I get that right?
Well, I think, I think so. In this particular document, we were referring to two-thirds was talking specifically about cost. And then there is the utilization is also, like you said, the number of claims that come in. I had more claims last year. They cost more. So those are two different things. And then there is the level of intensity as far as, did I need a 15-minute office visit or did I need a 45-minute office visit? So there's different levels as well. But I think generally speaking, 2/3 was regarding cost and then 1/3 was regarding an increase in overall claims as well.
How does it compare to pre-COVID?
Good question.
It was
Bobby Joe, go ahead.
higher. Yeah, I mean, we had our utilization was really stable for a long time. And then COVID, of course, we saw that big dip where there either wasn't services, there wasn't enough services, people didn't go to the doctor. And then this has been an increase from where we were. So I'm hoping that we get to a level now that we're back to pre-COVID where it's just, we still have a lot of claims, we have a lot of people, but it's, we don't see this increase.
All right, thank you.
So when you look at the explanation, the narrative that we send out to school districts and local unions and to our regulators who read it as well, and of course our colleagues at Blue Cross, we have them read these narratives before we send that out to make sure we're spot on. It's essentially the same message with some variation. The major cost drivers are prices. And to speak more broadly, we pay more for virtually every pill and procedure in the United States than our vast industrial counterparts. So there's nothing terribly surprising about this, but it is what we have to wrestle with every day as pool administrators when we are trying to pay claims. And as Bobby Joe alluded to earlier, make sure we've got ample reserves to cover unexpected contingencies and also to keep our regulators happy. So what I'd like to do now is to take you a little deeper into the specifics of how these costs are stratified among our members, the human lives and dependents that we cover. So, as
Mark,
Bobby
where are you
just
going to
said,
go so I can be sure to be on the right screen?
oh, thank you, Bobby Joe. I'm on page 7.
7, okay.
Utilization trends and concentration of medical spending is the title. Great. So, Bobby Joe's already touched on this. Although utilization is up, when you look at where utilization is coming from in the population of covered lives, it tends to be year in and year out, and this is true for large risk pools. It's stable. We do not see on a year-to-year basis, again, with this post-pandemic exception, wild swings in utilization. Large healthcare pools, whether we're talking state-based, regional, and national, they tend to be very stable with utilization. And what do I mean by this? So we just pulled out one particular year for this purpose, and it's 2023. The numbers for 2024 and 2025, when we have 2025, will be a little different, but you're going to see the same trend. You will not see aberrations. So look at 2023. We looked at roughly 19,000 claimants. And I asked Blue Cross years ago, gave their actuaries who are stellar, probably more work than they needed, but they were champions on this. And I said, I've been looking at national data. And I noticed that the national government for the last, again, at that point, 45 years, stratifies utilization and cost. Top 1% in spend, top 5%, and then the bottom 50%, the folks that utilize the least medical care and drive the least amount of cost. I said, I'd be really interested if you could do the same cost stratification for VHI, for our membership. So we took 19,000 of our lives in 2023, and actually we had this done prior to that year as well. Here's what the 2023 numbers show. Our top 1%, now this is 345 people. Our top 1% drive 25% of our total spend. They average, cost-wise, $255,757 in that particular year. 345 people, a quarter of our spend. The top 5%, which includes the top 1%, now we're talking roughly 1,700 people out of a pool of 35,000. They account for 52% of our spend, average cost, roughly $105,000 per year. Bottom 50%. These are the folks who get the least amount of care, cost us the least. We're talking now 17,000, roughly 17,300 lives. They accounted for just 4% of total cost at an average of $927 per member per year. Now, when you look at the same stratification analysis at the national level, it's almost identical. Our top 1%, a little more expensive, top 5%, right in the ballpark. Bottom 50% nationally, for nearly 50 years now, they account for 3 to 4% of spend, year in and year out. Very stable. So what this tells us is that, again, healthcare spending and healthcare utilization, very concentrated. Most members in our pool get very little care in any given year. If we dig a little deeper into the high cost cases, now I'm talking less than 500 people, 475 people in 2023. They incurred costs more than $98 million, 474 people. This represented 30% of our total cost that year. 60% of those 474 loans were new to it in FY23. Nearly $100 million in costs.
New to it.
500, new to that high cost cohort.
New to that group. Yeah.
Right. Again, these were folks who exceeded $100,000 in claim costs.
What's the cause for that? Is it age?
It's a variety of factors. It is price inflation for both medical care and for RX. It is perhaps multiple chronic diseases that need to be cared for. Age, acuity of care, as Bobby Joe spoke to. It's a variety of factors, but again, the chief problem here, major driver, is the price inflation.
Well, I wonder,
No, go ahead, Leslie.
I mean, I'm just struck by how little you're spending on primary care
Yes,
compared to what you're
Yes.
spending on specialty care. And we know it's in inverse as it should be. And this is just a perfect example of that.
I was actually going to come to that at the conclusion, but I'm really glad you raised it because the best investment in your dollar, healthcare dollar, is primary care and preventive care. No question on this. The research is categorical.
How do you make that change? How do you go in your world?
At the end of this, we'll
Okay.
talk about some of, no, that's fine. You're really good transition points. At the end of this, we'll talk a little bit about what VHI is thinking about in the future. And we've started to have this conversation about how do you keep people out of hospital beds if they don't need to be there? How do you keep them out of ER rooms if they don't need to be there? And to your point, you get them access to high quality primary care at the community level, and you make that accessible and you make it affordable. Because we know people are not getting the primary care they need. And inevitably, and my son-in-law is an emergency room doctor. He sees all kinds of folks at the ER room. He's in California who are there because they haven't gotten primary care, chronic disease management, preventive care when they needed it. They don't need to be in the ER, but they're there because they finally reached a breaking point. They deferred care for too long. They couldn't afford care. And again, didn't have access to primary care when they needed it. So we started to have these conversations within VHI about what does future benefit design look like. And this is one of the issues we're going to be tackling.
Can I make one comment on that, Mark?
Sure.
I just wanted to comment that we'll never see primary care cost as much as a high cost claimant because
Right.
primary care is not as expensive. So
Right.
it'll never be a high number just because primary care isn't as expensive as a cancer patient, a NICU baby, so there's a lot of really high cost folks that are, kind of in these predicaments. So our primary care, while our visit number needs to go up, and I get what you're saying for sure, and that needs to be a focus, it'll never be a top cost driver because it's not as expensive. So, which
Yeah,
is
but if you have less people go to the NICU, then you have less people going to the NICU. Right? And that'll drive your costs down.
Correct.
Of the 474, can I make the assumption that these were all, is there a breakdown of inpatient versus outpatient?
We could probably
100,000?
dig into the archives and pull that out. We actually asked Blue Cross for a breakdown of hospital visits. I want to say for 2022, it may have been 2023. And that document showed the number of outpatient and inpatient visits by hospitals in Vermont. So we have that data. We didn't bring it with us today, but if it's of interest to you, we can certainly share it.
I mean, I'm just thinking, did 474 people land themselves as an inpatient, a couple days as an inpatient?
Good question. I don't know. But we need to dig a little deeper into that. But I imagine some of them certainly were inpatient and outpatient visits. The largest cost from a hospitalization perspective is outpatient.
Thank you.
You're welcome.
And I'm sorry for my casual language, talking about things like racking up, and I do realize these are people's lives here.
No offense taken. And remember too, when we talk about these 474 people or any cohort, we're also talking about RX costs. And I think Bobby Joe, I can speak for you on this. This is an area where we spend an awful lot of time trying to figure out how to navigate a world that is driven by three big pharmacy benefit managers where there's virtually no competition. And drugs are under patents for 20 years. So we'll get to that. Speaking of RX, I just transitioned myself to the next stage of this presentation. I want to do a little bit with the RX world, what we just did with hospitalization and medical care generally. So once again, we're going to look here at 2023, just the first 9 months. We could have pulled 12-month data for you from any particular year. This was within reach when we were pulling together the testimony. So the numbers will change from year to year, but they will not change dramatically. The trends in particular will not change dramatically. So in the first 9 months of 2023, compared to the previous 9 months of 2022, we saw our RX total cost spend go from $46.2 million to $55.1 million. That overall inflationary trend represented 22.5%. Now, the specialty drug cost trend, and I'll speak more about this in a moment, that rose 20%, 20.6%, non-specialty medications, 24.9%. Specialty meds account for 56% now of our total RX spend. But here's what's really interesting when you dig into this number. And Bobby Joe and I see this time and again. We have quarterly reports with our pharmaceutical analysts. We see the same numbers again and again each quarter. So for the first 9 months of 2023, our specialty meds came out in cost at $30.9 million. 829 patients took them. Very small number of patients drive that amount of spend. I don't believe there's anything analogous in the American economy to those two numbers. Now, that 30.9 million represents gross spend before our rebates come in. Bobby Joe and I were talking about this yesterday. We have to wait months after every particular year to see what our rebates are going to be. But essentially, you got to get less than 1,000 people driving $30 million, nearly $31 million in cost in this period. Our total spend was $55.1 million, and they're accounting for $30 million. They represented just 3.2% of our total patient count and 2.3% of our total claim count. Again, very highly concentrated. The average cost per patient on specialty meds, $37,319 during this period. The next bullet covers 21,633 VHI patients. Their medications cost between $1 and less than $1,000. Their gross cost was just $155. When a medication goes from brand, and specialty is a brand medication, when it goes to a generic or what we call biosimilars in some contexts, the cost can drop 70 to 80%. Now, it doesn't cost a lot to actually manufacture drugs. Okay. It's that designation as brand generic where the rubber hits the road. So these patents that I referred to a moment ago, when a drug's under a patent for that long, it can be close to 2 decades before it moves from brand to generic. Humira, a very effective medication for acute pain, rheumatoid arthritis. That was our top drug with respect to cost for the last 20 years. The period of time I've been working as a VHI trust administrator, Humira has been at the top of that list. It just recently, this year, went to a biosimilar, a generic. And again, we see some significant cost savings there. However, we get the cost savings at the pharmacy, but we lose the rebate from the PBM, right? So again, cost savings, but nonetheless, not as much as we would like to see. All right, let me move a little quicker here. 246 VHI patients needed medications that cost $50,000 or more. Their claims represented, however, as small as that number is, 42% of our gross costs on RX. And 84% of our claims for generic medications, the least expensive on the market, as I said a moment ago. We spent several years back in the early 2000s educating our members about generic medications. They're medically efficacious. Fancy way of saying they work. Talk to your doctor about them, please. Don't get medical care via pharmacy commercials. Right? Generic medications work, and they're a whole lot cheaper. And we saw a dramatic, in fact, it was Blue Cross that flagged this for us. They said, early 2000s, your generic uptake's pretty low. And so we said, well, let's do something about it. And we changed the cost structure on our 3-tier pharmacy spend so that generics were much less expensive. And then we did a pretty aggressive education campaign. And now anywhere from 84 to 87% of our members in any given year take generic medications. Nonetheless, we are still sort of caught between a rock and a hard place on the specialty medications. We have an independent pharmacy consultant called Remedy Analytics, which operates on a national level. Remedy Analytics and the Blue Cross Pharmacy team work closely together to ensure that we have the very best RX contract with our pharmacy benefit manager, which is now Optum. But I again will say that there's 3 PBMs on the national market that control 80% of the business. So it's not like Bobby Joe and I have a whole lot of PBMs knocking on the door competing, right? And Blue Cross and again, Remedy negotiate very aggressively to make sure we're getting that good contract, but it's a pretty tight market when it comes to
Can
competition.
you toss the three?
Optum, I want to say, is it Express Scripts and Caremark?
Caremark.
Caremark, Express Scripts, up. So like any trust administrators, we're always looking to the future. How do we reduce costs? And how do we do that in a responsible way? How do we address the systemic drivers that we've talked about today? How do we educate our members? And how do we do this without compromising access to care? Making sure people have access to affordable, comprehensive care. So just to touch on a few things, you heard a lot about reference-based pricing this week, so I am not going to go over that ground again in any detail, but our board of directors had a presentation on reference-based pricing, benchmarked to Medicare rates in 2023. I started researching it in 2021. The management team started talking about it that year and in 2022, and we thought it was worthy of our board of directors to hear about it from us and from a national expert, Marilyn Bartlett from the National Academy of State Health Policy, who also led the effort on RBP in Montana. We were also, of course, very intrigued by Auditor Hoffer's report in 2021 about RBP and state employees and prospective savings there. And of course, we have noted that the Oliver Wyman report has urged the Green Mountain Care Board to begin moving in the next hospital budget cycle toward reference-based pricing at 200% or less of Medicare. And then we've been tracking, me in particular, what other states have been doing, as I testified earlier this week. I am actually very proud to say that I think we're probably the first commercial risk pool in Vermont that began looking seriously at pricing, and we'll continue to track those developments in the policy world here and also in the medical world. VI also endorsed the prescription drug affordability measure that this legislature passed last year. Vermont NEA first proposed it with allies in 2020, just before the COVID curtain came down. We came back with the initiative in 2023 and 2024, and my memory serves, Blue Cross Blue Shield of Vermont endorsed that initiative as well, as did others. And now we know the Green Mountain Care Board has a new regulatory division that will be building a framework and a methodology to make healthcare costs for prescriptions more transparent and also look at ways to begin saving money in that domain. Other states have done the same thing. Maryland really launched this. In fact, I just talked to someone in Maryland 2 weeks ago about what they're doing. They're going to begin capping prices in Maryland on high-cost medications this summer. They're going to do the first 2 big drugs cost-wise for them this summer. They're going to be expanding that, and it'll be for the public sector initially. But they now have a bill in the legislature that they believe is going to pass that would expand the scope of authority of their prescription drug affordability board to the entire commercial market. We'll be watching that. We will be watching that closely. Continuing to work with Remedy Analytics. One of the things we're really interested in is a new crop of pharmacy benefit managers who are beginning to challenge the big three. They call themselves Next Gen PBM. Somebody got paid probably a lot of money to come up with that name, but they're a small group at present. I want to say 7 or 8 nationally. They operate in different regional markets. We've been researching this, and we've asked Remedy Analytics to help us go a little deeper with this research. These new PBMs can perform the functions of the big three. They see themselves, though, as having a greater community benefit focus. Their profit margins are markedly less. The big three can operate on a 30 to 40% profit margin.
Well, are they public?
Yes,
So the new ones are public too?
yes, they can serve the public sector.
No, I don't mean that. I mean, do they have shareholders?
Good question. I think some of them do, but I can research
That's a
that way.
worry for me. I mean, when you're
Yeah.
operating in a for-profit world as opposed to.
I agree.
That has different motivation.
I agree. And so what they said in a workshop that I attended with 3 of them were explaining their business model and their costs and why they can operate at such a lower cost. And they said, look, we can do what the big PBMs do. And we can offer you more simplified revenue and cost structures that reduce some of the complexity around rebates. This rebate world is just a nightmare at times. But fundamentally, we believe that you should have access to high quality services and the same comprehensive services we depend on from Optum and before that Express Scripts, but at lower profit margins. Their profit margin, they say, is somewhere between 7 and 12%. So if you can get a pharmacy benefit manager to operate in the Vermont market at a markedly lower profit margin and deliver the same quality services, you're looking at some substantial savings there. So we're going to be looking at that more closely. We are also looking at new benefit designs, which I alluded to earlier. How do you, in this current market, and all the changes in medical care that have evolved since we last changed our plans roughly a decade ago, how can we reduce costs within those plans? How can we, for example, inspire, induce, incentivize primary and preventive care more to reduce our hospital and ER spend? Do we need 4 plans? We'll be looking at the number of plans. We'll be looking at the cost sharing structures within those plans. Can you incentivize high value clinical care through certain out-of-pocket cost structures? So for example, should primary care be under a deductible? Or should primary care be a copay? Would those different cost sharing structures incentivize different kinds of care? We have not yet begun in earnest to explore all of those, but those are some of the questions on the table. And most immediately, the number of plans and also, again, different kinds of cost sharing structures that will be available to us. We'll be looking at telehealth services. The pandemic revolutionized telehealth, I think, as we all know, and there are different plan designs out there right now that are encouraging members to use telehealth more frequently and for different kinds of services. We recently launched a physical therapy and pain reduction collaboration with Hinge Health, which is a national vendor in the physical therapy realm, virtual physical therapy realm. And then exploring benefit design options that might be able to facilitate easier access to primary care, mental health, chronic disease management. Most of the costs in any healthcare pool are for chronic disease management, chronic disease care. Roughly 70 to 80% of spend in any given year, and this is true nationally, is for treating people with chronic diseases, 1 or more chronic diseases. If you can manage those diseases at the right point and place within the medical system, again, as much as possible, community-based care, primary care, mental health, home health, if you can manage those conditions more effectively, you will see an impact on total costs. And that would include as well helping people stay drug adherent. This is a major driver of cost. People not being able to afford their medications or not taking their medications, even if, at least on paper, they should be able to afford them. So drug adherence is another important factor as we look at benefit design in the future. Let's see, finally, we're also talking more about centers of excellence, what Blue Cross calls in its world centers of distinction. These are medical centers in Vermont and outside of Vermont that are exceptional for the quality of care they provide, for having reduced infection rates, lower rates of readmission, especially if it's hospital care. There are centers of excellence for knee replacements, heart replacements, heart transplants, cancer treatment. We believe it's time for VHI to begin diving into this in more detail in collaboration with Blue Cross and others. Can we direct certain kinds of high-cost care to centers of excellence here in Vermont or outside of Vermont? And by doing so, reduce our costs, because these, again, are centers that are high-performing. They have fewer admissions after your initial care, and they have a track record of lower costs. Sure, please.
We discussed yesterday, I think it was yesterday, sometime this week, sort of, the fact that the price differential between different facilities for the same services. Are you doing anything to give the information to your enrolled people, or maybe incentivizing doing, here, go here for that MRI instead of going here? And
that's a really good question. And it's been a topic of conversation. And I caught some of Ms. Teachout's testimony the other day on this point. Our members have access to the tools, the cost comparison tools that Blue Cross has developed. I'll call you Sarah. I share Sarah's commentary about both the benefits and some of the restrictions around those tools. In some respects, they can be very illuminating. In other respects, they can be very complex and not terribly illuminating. And we also know that for most people, where they get care and how much is determined by their provider, which tends to minimize, I think, the amount of dependency on tools of this sort. Nonetheless, they are available to our members. We have advertised them. We encourage them to use them where they can. But what we also find, and I believe Sarah touched on this, is that there are such wide variances in prices around the state. It's very intimidating for people who want to discern what one particular price costs in a certain hospital versus another. And the national data on this is also really revealing. And again, I think Sarah touched on this. Most people don't use these tools and they don't like using them. That's what I hear a lot from my members. They tend to, again, to depend a lot on their provider's direction, which makes sense. At least it's rational. And this is actually true regardless of income band. We find in the research that high income people, as well as folks in the middle class or low income people, they all tend to have the same attitude toward these plans. Folks with much higher education levels, as well as those without. As a rule, we don't see a high volume of people using these services and these tools at a national level or at a state level. Whether that is something that can be corrected or whether it's ultimately something that will really bend this cost curve remains to be seen. But that's at least what I've heard from my members and what the data shows. And Doug Hoffer, by the way, Auditor Hoffer has also done some research on this. In fact, it was part of his RBP report. The second half of his reference-based pricing report dealt with, I think, New Hampshire's experience in particular with these tools. And go ahead.
But you could identify, you could identify like your top 20 procedures and you could put education out to basically say, hey, if you are having any of these, contact us and we will, guide you on, the best place to go. And maybe if you go to the best place and you're willing to drive 20 miles, we'll give you, I don't know, Starbucks gift card. I don't know, anything to.
That may well be something we can do. In fact, one of the reasons I'm interested in Centers of Excellence is because I think it merges these two worlds. If I can say to my members, look, you go to Hospital X for a knee surgery, your outcomes are likely to be very good. And VI is going to save money and you're going to save money and the taxpayer saves money. That is certainly an area, if we build out, where we can do very effective education. Can we drill down into our top 10 procedures and which hospitals cost what for each of those procedures? Yeah, we probably could. It might be something we should look into. Yeah, we haven't done it today, but again, doesn't mean we can't do it. Finally, I want to give a shout out to our wellness colleagues who are not here with us today. This is probably, Bobby Joe, I think this is true. This is probably the most popular program we have ever offered. Gets high marks every year. The purpose of this wellness program, which has been around since VI's existence, pretty much, and we started in the mid-90s, is dedicated to education, activities, programs that help you live a healthy life with respect to nutrition and exercise, dealing with stress, and just identifying those factors in your life that may be making you crazy, exhausted, not doing what you need to do in order to be healthy. We have wellness leaders in virtually all of our supervisory unions, and they disseminate information and facilitate programs for our school staff. And again, I can't say enough good things about the program. It is immensely popular, and we're going to continue to offer that and refine it. And we also collaborate a great deal with Blue Cross on our wellness program. They've been very helpful with us in terms of supporting the program and making it as effective as it can be at the local level. The last part of this presentation, and thank you for your patience, there's an awful lot of numbers here, are the 4 plans that we offer. I think Bobby Joe touched on this. All of these plans have to be provided by every member group, every public school member group in VI. You can see generally the benefit structures that are offered, consistent with what every comprehensive health insurance plan offers statewide in the Blues Book of Business. And correct me if you think I'm wrong there, Sarah, but I don't think you're going to see anything here that is not common in the insurance market as a rule. And then the 4 plans with their metal monikers. We were designing them not long after the Affordable Care Act launched. Everybody was in the metals. And then you can see the out-of-pocket costs and how they're divvied up by copay, deductible, and co-insurance. And then there's an awful lot of numbers there. And frankly, this graph always makes me dizzy. So if it makes you dizzy, you are in good company. All right, let me take a breath and give you an opportunity to ask questions or make comments.
I'm just looking at this graph. I love these graphs. I might be the only one, but I'm just thinking about, is there a sense on the percentage? So all these plans need to be offered.
Right.
Is there like a percentage of what plans are chosen? I mean, is
So roughly,
percentage gold?
Bobby Joe, again, jump in, please. I think roughly 90% of our members in their gold CDHP.
Yeah, the way it was a popular plan to begin with, and then the way the statewide bargaining ended up turning out the decision, it made the gold CDHP a really advantageous plan to go with. It kind of gave you the best bang for your buck, so to speak. So it has the overall lowest out-of-pocket exposure and has a lower premium. It has the second lowest premium, but the out-of-pocket exposure is the lowest for folks. So it makes the most sense. So I think it's closer to 85 or 88% of folks are in the gold CDHP. The silver, I think, is close to 7%. And then the platinum and gold each have, a few percentages.
Thank you.
And as Mark mentioned earlier, that is one of the things we're thinking about while we're talking about plan design and such, is do we really need 4 plans if so many people are in one particular plan? So we'll likely change that in a coming year to probably 2 plans, I would guess, but that's not been decided yet.
And that will not only make education easier for our members and certainly help school boards, it will also help central offices. We'll have to administer these plans if there's 2 rather than 4. And Bobby Joe does the lion's share of work with the central offices, the business managers, human resource people, meets regularly with them. And to whatever extent we can simplify or streamline their administrative work, we want to do that. And 2 plans would certainly help in that regard.
So we talked a lot about prescription drug costs. And I'm looking at the gold CDHP, which 90% of the people are in. So so their prescription deductible is included in their medical. So they have a total, let's assume you're single. Let's not get into families. $1,800 is their deductible. Their prescriptions are included in that $1,800. So that's their deductible.
So the 1,800 would incorporate, again, Bobby Joe, if I misspeak, you just chime
Yep,
in.
I gotcha.
The 1,800 would be combination medical and RX, maximum liability deductible in a calendar year.
Yep. So their HRA picks up all of that 1,800 except for 600.
Single coverage under Gold CHP, I think it's 600, Bobby Joe.
Yeah, so what happens is once the $1,800 deductible is met, it then goes into an 80-20 split. And then so it has a deductible of 1,800, and then the employee is responsible for 20% until they max out at 2,500. So that's where that additional $600 comes from. And the HRA is valued at $1,900, so it pays for their deductible, and then $100 toward their co-insurance, which means after that HRA is exhausted, their exposure in a calendar year is $600 for a single
coverage.
And so their HRA picks up their deductible from the beginning. Or they have to first pay their 600 and then the HRA picks up?
The HRA pays first. I do want to note on the prescription piece, that there is I guess I would just say a law in Vermont or a statute in Vermont that has a cap on prescriptions. So even though the deductible is 1,800, the max you can pay for a prescription in this section here, if you can see it, me moving my mouse, is
Yep.
actually 1,650. So that's an annual cap for everyone in Vermont, that it can't be higher than 1,650 for an individual or double that for the family. So depending on where they're at with their deductible will depend on whether or not they would ever pay anything for prescriptions.
And that pertains to self-funded plans as well? I mean, I knew about that cap. I guess I didn't.
Yes, for
But
us
it
it is
only was
anyway.
the market.
Yeah,
Yeah,
sometimes some of the rules that are only that are set out for fully insured plans, they apply to VHI as well for whatever reason.
Okay. Ellen,
When you say you negotiate with school boards on the pricing, you
We don't negotiate.
okay,
So you have a statewide bargaining structure for
Okay.
negotiations, which Bobby Jo alluded to in her remarks. There's a team of negotiators for the union, there's a team of negotiators for VSBA, and there's two unions, there's Vermont NEA and AFSCME. So those parties come to the table, negotiate via a process that's set in statute.
okay.
Yeah. But Bobby Jo and I have nothing to do with
Okay,
that.
that's what
Fortunately.
when I heard her say negotiate with the school board,
Yeah, no. Yeah, no, it's easy to be, because it used to be that way. I used to negotiate at the local level. Now it's at the state level.
so because I said that this process is such an enigma to me, so VHI's role is to just like design the plans?
Design, price internally. I mean, when we say design, let's talk about benefits, costs, which would be premium and out-of-pocket costs. And then again, in collaboration with Blue Cross, establish what the networks are going to be. So we operate within the Blue Cross network. When I explain health insurance to people, high level, I say there's three things as an insured person you care about. You care about what the benefits are, medically and RX wise. You care about what the costs are, premium and out-of-pocket, and who's paying what. And you care about the medical networks, where you can get care and from whom. That's how I generally explain it. So VHI works in those three domains. And we administer the plans, as Bobby Jo said, on a day-to-day basis. So if someone in a central office has an issue, 9.9 times out of 10, they go first to Bobby Jo. Most local union leaders and union members or their family members, most of the time, if they have a question or concern, they come to me. Bobby Jo and I go back and forth an awful lot now virtually, most days when we need each other's help in sorting through these problems. We had an issue come to us yesterday. It's literally a 20-year problem. It originated 20 years ago, and she and I had to work it out both for the school district and for the local union, which we did. So that's how we function. And the role of the statewide bargaining commission is to determine how the cost sharing is going to work, consistent with the design that VHI has presented.
VHI is made up of 3 members of the NEA and 3 members of the school
On the governance board, that's correct.
governance board.
And in terms of day-to-day operations, VSBIT's team, the Vermont School Boards Insurance Trust, and then I represent Vermont NEA as the trust administrator for the union.
Can you explain what VSBIT is?
Oh, yes, Vermont School Boards Insurance Trust. Bobby Jo, I'm definitely going to kick this one over to you.
The Vermont School Board Insurance Trust offers multiple types of insurance to all schools in Vermont. We only offer to Vermont schools. We have property casualty, workers' comp, unemployment, and then we have this arm that is VHI, which is the health, dental, and life and long-term disability.
Okay, so VHI is part of VSBIT?
VHI contracts with
It's an arm of
VSBIT.
VHI
It
is the
kind of
most.
lives at our office other than Mark's portion of it. The VHI board contracts with VSBIT to run the pool and run the plan.
Remember what
And
Bobby
the
Jo
wellness
said earlier?
program.
I'm sorry, Bobby Jo.
Sorry, no, go ahead.
Well, Bobby Jo said earlier, VHI has no employees.
Yeah.
Right? It's probably the most unique health insurance pool in that regard in the country. We have no employees, but we have trust administrators. So VisBid contracts with, VI contracts with VisBid for Bobby Joe's services and John's and Chris's and our wellness team. And VI contracts with Vermont NEA for my services and some supplemental administrative support that Vermont NEA provides for my work. But if you were to look for a VI office anywhere, you wouldn't find us.
Yeah, Sarah, did you wanna?
I think one important thing that they forgot is that they're managing the solvency of the healthcare trust fund. So Blue Cross and Blue Shield of Vermont manage the solvency for our fully insured members. They are doing that for the teachers. I think that's a huge part.
Oh, thank you. That's right. And yeah, no, I appreciate that. Thank you, Sarah. And, you know, Bobby Joe talked about our net position, which is a fancy phrase for reserves. And to Sarah's point, we spend a lot of time with our eyes on those reserves because we have a fiduciary responsibility to our members, to school districts, and certainly to our regulators, and by extension to taxpayers. And as a self-insured trust now, we carry all that risk.
How are your reserves?
They're okay. They're not as good as we'd like them to be. We have a net position policy. Let me qualify that. That's a little too strident and crude. We have a net position policy, a reserve policy that we'd have ideally like to have 15% of our total costs in reserve. So every year we shoot to get as close to 15% as we can, to 15 if we can, but we like to stay in the neighborhood of 15% if we can't quite nail it. And Chris Roberts, who's not here today, and if she was, she's very impressive, and she watches these numbers like a hawk and lets Bobby Joe and I and John Steiner know routinely where we are with our reserves, educates our board at every meeting about what we're doing with reserves. And at every rate setting process, every rate setting cycle annually, this question of fiscal solvency, as Sarah identified, is front and center. What do we need to pay our claims, our state and federal mandates, et cetera? And what do we need in net position reserves in order to maintain the solvency of the pool and honor our mission to school districts, a teachers' retirement system, and to all the employees, active and retired, for whom we're responsible.
Any other questions? I have one more, but
I think I
yeah.
have. How much money do you take in on a yearly basis?
So there's two numbers in this presentation. You'll find them on page 3. We anticipate in FY25 that we will take in $350 million. Now that is for all of our work, right? It's claims,
You're saying
it's for premiums, 350 million. You'll find the two big numbers here on page 3, 350 million for premium admin. I mean, it's all close to the premium, but it's for claims, it's for administrative costs, it's for the wellness program, state and federal mandates, the whole shooting match. 350 million in FY25. That's a projected figure. At some point in the future, we'll have an actual number for you. And then in FY26, and obviously we're way out front here, but we're projecting, looking at the trends, meeting with the actuaries at Blue Cross, watching all our numbers internally. We anticipate a projected spend of about $382 million in FY26.
Well, that's why I just calculated, that's sorry, 338 million that you're projecting to spend if you do 6.5 million a week.
Well, FY25, that's the 350 million is if we, well, remember, it's 6.4 million in anticipated claims per week, but that is the biggest chunk of that $350 million. But in addition to that, we have administrative expenses internally with Blue Cross, and we have state and federal mandates, and we have a wellness program, et cetera.
Yeah, so it leaves $12 million unless I'm doing it all wrong. Never mind, I'll.
Well, reach out to us, please. We can certainly dig into those numbers
Yeah.
with you if you'd like.
Yeah, there's a lot of numbers being thrown around for sure.
Does every individual district or school negotiate their, I mean, I'm looking at the monthly rates for the plans, 25 and 26. How much is the actual employee paying versus what's
Well, remember, the statewide bargaining dynamic determines these costs, both premium share and out-of-pocket share, which we've covered. So at the premium level, school employees, licensed and non-licensed administrators as well, of course, 20% of the premium. Then the out-of-pocket costs are the numbers we've already talked about. But that's all set at the state level. Local school districts and local union leaders or local union teams don't determine those numbers. They
Okay,
used to, but not any longer.
but it's set at the district level,
It's set at the state level,
state level,
and then the local school districts
yeah,
implement it.
implement it, okay.
So they're taking,
Every teacher across the state.
paying 20% of the premium.
20% of their
The
premium.
central office personnel who depend so heavily on Bobby Joe, they're the ones deducting from the paychecks.
I think the only outlier to that, Mark, is there's still a handful of
Oh, thank you. Yes.
non-licensed folks that if they were not at 80/20, they're going up 1% a year. So for example, if they were paying 90%, 10%, and they were paying 10%, each year it goes up to 11%, then 12%. So they're working toward that 20%, but they may not be there yet. And that's not all schools, that's just some of them.
Yeah, I mean, I checked in with my colleagues a few months back on this. Thank you, Bobby Joe. It's an important qualifying statement. Most school employees today are at 20%. But to Bobby Joe's point, when this statewide bargaining process began, we had people at 10%. The licensed personnel jumped immediately to 20. The low-income support staff individuals, their progression to 20 was slower and more incremental. And most of them are there today, or they're within shooting distance of it, right? They're close.
So this was 2018, so.
We started bargaining the first time statewide. 2019 is when the process began. The law passed in 2018.
Yeah,
But
I
I
think
think
it went
the-
into effect January 21, I believe.
And I
Statewide bargaining.
just had a real quick question regarding your section on utilization trends.
Yeah.
Just so I'm clear in my mind, this information is only on members who are, did you say the current employees? They're not the retirees, is it?
My understanding is these numbers that we pulled for today's testimony are for active employees.
Jeff,
Bobby Joe, true?
I agree, yeah. And I would like to just hop back to that question, 2 questions ago, when we were talking about the 6.4 million being the 332 million. And that is correct, because that is the claims versus the what we're taking in premium. So 350 would be what we expect to bring in for premium, 332 would go out, because remember, we pay about 90%, 89% out in claims. So the difference between those two would be to pay for wellness and stop loss coverage and administration, things like that.
great numbers.
There will be a quiz later next week.
Not good numbers, but great, a lot of numbers giving us and a lot of information. Thank you.
Thank you for your time today and again for your patience. We know it's a lot of data and we're happy to come back at any other time. And also, if you need clarification on any of the numbers, please feel to reach out and we'll make sure you get what you need.
One quick,
Thank you.
of course, do you require the teachers, the participants in your plan to get their medication through Optum? Is that a requirement?
Optum's our PBM.
Mm-hmm.
So our RX formulary, prescription medication formulary, is Optum's formulary. And that also is a subject of negotiations. And yes, so if you're in the VHI pool, you're utilizing a formulary that is the Optum formulary. The PBM contract that is negotiated by Remedy with support from Blue Cross Blue Shield of Vermont will be setting discount rates, terms for rebates. The PBM contract, I often describe it as abandon hope all ye who enter document. These are immensely complicated contracts. And fortunately, we've got folks at Remedy at Blue Cross who understand how they're structured. So what we do with Remedy in our quarterly meetings, we are tracking these claims on a quarterly basis and seeing where the trend is on spend. And that in turn will drive benefit design decisions in the future. And our members, fortunately, they don't have to worry about any of that. They're just making sure that the medications they need are on the formula.
Thank you.
Thank you, folks. Appreciate it.
Yeah. We're just gonna wait for the slides to come down.
Bobby Joe, thanks.
Thank you, Bobby Joe.
Thank you all. Appreciate it.
Hi, I think we're joined. I'm not sure. Do you have an updated? So we have Mark with us and Mike as well. And just getting, perspective on teachers' health insurance, and your role in it and how it works.
Sure. So I'm Mark Koenig. I have many hats, but for purposes of this discussion, I'm co-chair of the commission that Mark and Bobby Joe were just talking about, the deal with the statewide negotiation for healthcare benefits for public school employees. Mike is my counterpart. I work with the employer commissioners. Mike works with the employee commissioners. We should have started our third round of negotiations this past April, and the two of us kind of sat down and said, this is kind of silly. We are going to negotiate hard and fast for 9 months over plans that neither of us particularly like, that are far too expensive for taxpayers and teachers. What can we do? So we used a clause within the current arbitrated agreement that allowed us to extend the current agreement. We did so for 2 years, and we're trying to solve healthcare. So we are 1 year into this. We have been talking with VHI. We've been talking with Green Mountain Care Board. When we started our, Quixote at the Windmills event, we didn't know others were going to come along for the ride. So we were not aware that Green Mountain Care was doing their hospital report or their reference-based pricing report. We didn't know that other organizations were trying to figure out similar issues about how to contain and make sustainable the costs of benefits. And so it's been a pleasant surprise over the past year to find that we have a lot of different groups who are trying to figure out the same thing, including all the people around your table. So much of what Mark and Bobby Joe covered kind of takes the wind out of our sails. We don't have to cover all of that. So we will not dive into all of those numbers. I think we can, unless Mike has something specific he wants to go over, I think we're just open to questions from you.
I would just like to make a couple of comments. I think Mark spoke eloquently to the process and where it's at. I do want to share that this was a very contentious process, the first 2 rounds, and that's not finger pointing in any other direction except, both of us. But it was very contentious, very fought out, ended up in an arbitrator decision the first time, an arbitration panel decision the second time. And each side got something they wanted out of that. But basically, we were unable to negotiate that cost sharing agreement without help from a third party. And Mark is correct that in a phone call, it was very, very clear that neither side can afford this and the constituents within each of those sides. And I do want to point out just one group within our constituency. Often the employees are considered teachers, and that is a majority of the people as members. But I think it most dramatically hits the ESP and support staff members whose wages are substantially lower, and yet the premiums and 20% of the same premium has a disproportionate landing on their financial health. So there is a group of call it our side, air quotes. I think that they are particularly hurt by these ever increasing costs, which largely are not a result of negotiations. They're a result of systemic problems that we have to deal with, that we really have little to no control over. So Mark and I just said, we have more in common, and we can argue after we find ways to hopefully offer reforms to the system. Then we can talk about cost sharing in a new light, because we've helped slow the growth or flatline the growth for taxpayers in Vermont, for teachers and ESP within the system. And for last year, we've been talking to everybody who will talk to us, Mark taking the lead in many ways doing that. But we've talked to everyone, and we've gone to meetings, and we've encouraged and met with VHI to look at the plan design. We've done all those things in the effort to come up with a better mousetrap so that we spend less taxpayer dollars and less income from employees in the education field. So I just wanted to frame that. It's really remarkable. If you'd been around for the first two cycles of this negotiation, it's really remarkable that we're working together for a really good purpose.
Yes, and thank you for the reminder that, we tend to keep saying like teachers' health insurance, but thank you for the reminder that it's not just teachers, it's everyone that works in our schools. Topper, you have a question?
Could you elaborate a little bit on the systemic problems that you just mentioned?
Within healthcare costs, or within how it impacts school budgets? Which ones?
Well, you talked about the cost that you were trying to negotiate, the premium payment and all that, and you said it was.
Yep. So like last year's was a 16% plus increase. This year's was almost 12%. Our commission has absolutely no control over those percentages. That's handed to us. And it says, okay, your premium is now going to be $10,000. You figure out how you're going to divide that number up. We have no control over that number, though. So your cost of healthcare is going to be X. You decide how the school board is going to pay for part of it, and the employee is going to pay for part of it. Our sole job within statute is to decide who pays what percentage. The only other thing we have within statute is that we can give recommendations to VHI about plan design. We can't tell them what to do, but we can say, hey, wouldn't it be nice if? So the systemic problems that Mike was alluding to is that we're handed the number, and then we have to divide up how that's covered.
And those cost drivers are what Mark and Bobby Joe went through in great detail and really educationally helped us understand. We've heard it several times, and we work with it, but those numbers are the prescription drug high cost, the high cost of the hospitalization, and those kinds of things that are, they really drive those increases in costs. And Mark, if I'm not 100% fair, or please feel very free to jump in here. This is hitting our state in ways that you're now getting bounce back from. And that's in budgets that don't pass. The 80% that the employer, that the school budget pays in, when it goes up with those double-digit increases, is very, well, it's having an impact on those budgets passing. When we sit down and negotiate in good faith a master agreement with our employer, with whether it's the district, for example, the amount of increase that 20% takes out of any kind of increase we get at the other at the table, it takes a huge proportionate amount just to pay for that increase that we got as an increase in say pay or inflationary costs, those kinds of things. So the employee is struggling to keep their pay at a pace that keeps up with that, which is a cost pusher to the budgets and what the employer is negotiating. And it just keeps taking a bigger and bigger chunk out of both sides. Yep. And I just, I always remind folks that teachers are taxpayers too. So, it's a matter that each of us, something has to change fundamentally for the state to be able to afford healthcare for its employees in the education system.
Yeah, to Mike's point, it used to be that benefits took up about 10% of a total compensation package, and it's closer to 20% now. So before this commission came into existence, a local school board would negotiate the entire package, and you try and balance benefits and salaries or wages. And now the benefits portion is taken out of the hands of local districts, and they get what we have decided, and that is tacked on to the end of a master agreement. But now what's being negotiated is a salary or a wage, but the school district office is looking at total compensation, and if they have had to do an increase of a 12% increase on benefits, that eats away at any kind of raise they could have given. So the employee feels like they're not getting a raise because there's nothing extra going into their checking account, even though the total that the district is paying to them has gone up by 12%. So that's
Mark,
where the problem lies.
Oh, sorry. Mark, thank you. I do, Mark Hage mentioned before, and Bobby Joe were talking about the incremental increases in the ESP support staff part of this. In places like before healthcare blew up as an expense, in places like the Northeast Kingdom, some employees are paying 0% copay because that payment to the healthcare system was an entirely different ratio and relationship, and then that was a kind of like water finding its level kind of a thing. Those places are particularly hit because their tax base hasn't increased, yet they're now having to find ways to pay employees who have to be able to afford the 20% that they're now paying, that they were being paid, they were given as in lieu of a benefit. So that relationship has fundamentally changed across the state, whether you're in a rural area with a tax base or whether you're in an more urban area in Vermont that has a different tax base. So that's been a fundamental change going statewide that really hurt some of those members because they weren't able to make up as much of that in the salary because to be fair to the employer side, the tax base couldn't support that change. So it kind of messed up that part for proportions of rural areas of Vermont that were getting the benefit at a very low number. Therefore, we put in the incremental growth rate for the ESPs at 1 to 2% through different cycles. Most everybody has now achieved the 20% level, but it is accurate that there are still a handful that are still reaching up to that as this progresses.
Yeah, and it's maybe 5 or 6 districts statewide.
Yeah.
It's a very small number that's still working its way towards 20. So the vast majority of all public school employees are at an 80-20 split for premiums.
And so, your organizations approve of reference-based pricing?
I
It's certainly
think
the employees commission to look more into get as much information about that, and from a Vermont NEA perspective, to support that. I mean, currently, and Mark Hage is in the room, so he can correct this, but if I'm inaccurate, but I think that VHI is currently paying at a 316% Medicare rate. Medicare is a certain rate, and it's 316% more what VHI payments are. And so I think there's somewhere between Medicare and 316% that might be able to save some money in scale on this system. And I think that's an incredibly important concept to look at. Look at Montana and some of those other states that are doing this is an incredibly fertile ground for potential savings there that needs to be researched and fleshed out.
Yeah, and our side is of the same idea. It's a good concept. It should be considered. I feel like the report that Green Mountain Care put out, and then just most discussions I hear about reference-based pricing, kind of ignores the elephant in the room that you have to have agreement with the hospital systems that they're going to then abide by it. And since we pretty much have one group that covers the vast majority of our state, and they don't seem inclined to want to go along with this. So unless it is legislatively required, groups like ours are not going to have the power. You know, the VHI can't go to Vermont Network and say, we demand that you only take 225% of Medicaid. Vermont's going to, or the University of Vermont Network is going to say, and so we don't have the teeth to have that. But I definitely think it's something that needs to be researched and figure out how can Vermont make that work. You know, we're not Montana, we're not Oregon. We have different issues, but the concept itself is definitely something that should be further explored. Figure out how it could work.
Thank you.
Go ahead, sir.
Go ahead. I just said thank you. I thought you
Oh,
were
so,
done.
sorry. I do. It's hard on Zoom. It's hard to pick up on cues where people are ready to go. I just have heard in Montana under one, you know, the geographic size of the state is one thing. The structure of the hospitals and the negotiations between the hospitals directly. Oregon's maybe a better model where they did it legislatively. There are ways to do this that there are savings that we're not talking double-digit increases. In Montana, there was not an increase for 7 years. If you're talking about that, that leaves money on the table for salaries, benefits, and programs within schools. And that's why reference-based pricing is so attractive to, you know, the Vermont NEA side of this equation, is that if it can be put into place, some real and significant savings. And Mark recently, to both sides of the commission, shared that the hospitals that were put underneath this system, none of them went out of business. So there's certainly the other side of the coin is that the hospitals say they can't even keep the doors open now. But yet in two larger scenarios, and with some more explanation, the hospitals didn't go out of business. So they had to format how they offered services, how they structured, you know, expenses and such, but they were able to stay healthy providers for their communities. So this isn't about give us reference-based pricing and destroy hospitals. And when you have that kind of conversation, I think it behooves you to go deeply into that and find out what the real story is, what the data is, and maybe set it up so that some of us can make a better cost structure for the state.
Anyone else have any questions? Well, thank you for coming in. Thanks for joining us today. We really appreciate your perspective.
Thank you.
Well, thank you for asking us in.
I think that we've heard an awful lot today. And I think that we're going to our next guests are speaking more on a state of Vermont employees perspective. And I think today I really just want to contain this to school-based employees. So I think at another time, we're going to invite our next two guests in. And I think we're going to end for the day today. I think we've all had a lot to think about this week. All right, so we can go off of live.